And by Uganda and DRC, and going in this humanitarian conflict area, supporting them is the best medicine for the entire world in support of solidarity of DRC. It's a complex, as DG said, hundreds of thousands displaced population, insecurity, travel restrictions. Countries have sovereign, they do their own risk assessment, but they do have to provide to us the justification and the rationale behind their mandates. And we are seeing more and more countries. But currently, our top priority is to work closely with DRC in ensuring all the contacts are traced and all the patients suspected are put in the clinical pathway in safe environment and with the best care provided.
Thank you very much. Looking if anyone else would like to add something. If not, we will move to one more question from the room.
Can I add something? I think it's important to remember and recognize how Ebola is transmitted. It requires direct contact with blood and body fluids of an infected person. So it's not casual contact. It's not airborne. I think we need to be aware of that. And this relates to travel restrictions, which are not supported under the IHR recommendations. And we've heard about contact tracing and quarantine of those.
Thank you very much, Professor Bloomberg, for adding that. Let's take one more question from the room. Nina Larsen.
Thank you very much for taking my question. Nina Larsen, AFP. I was wondering if we have any indication of how long Ebola has been spreading for, or how long it had been spreading for before it was detected, and if you have any response to U.S. Secretary of State Marco Rubio, who yesterday said that the WHO was a little late in identifying this current outbreak. What role do you see that WHO had in that detection, and what impact do you think the U.S. cuts may have had on the speed with which this response happened? Thank you.
Thank you, Nina. Maybe we start with Anaïs.
Thanks. This is an important question. I think a lot of people have questions around that. So regarding the detection of this outbreak, again, I would like to remind everyone that the surveillance starts within the communities and starts with the health authorities in every single country. As soon as WHO was aware of the signal, support was provided to DRC to investigate as quickly as possible. And this ended up with a confirmation late last week. Investigations are ongoing to ascertain when and where exactly this outbreak started. Given the scale, we are thinking that it has started probably a couple of months ago, but investigations are ongoing, and our priority is really to cut the transmission chain by implementing contact tracing, isolating, and caring for all suspect and confirmed cases. I defer to my colleagues for the other question.
Thank you. Dr. Janabi, would you like to add something?
Yeah, on top of that, I think it's important first detecting outbreaks such as Ebola in a complex setting like Ituri province in the DRC is inherently challenging. Surveillance systems rely on a combination of community reporting, local health facilities, lab confirmation, and a partner coordination. So in remote or insecure areas, it can take time for cases to be recognized, samples transported. I said the other day, from Ituri to Kinshasa is 1,700 kilometers. So until diagnosis is confirmed. So it's very important to emphasize that primary responsibility for detecting outbreaks rests with national health authorities as part of the international health regulation framework. So the WHO role is to support countries technically, operationally, and with coordination so that signals are rapidly investigated and confirmed. I just wanted to add that.
Dr. Mahamoud?
Thanks. Just to build on the Anais and the point raised by Dr. Janabi, is to put this in context. This outbreak is happening in a highly endemic other diseases that present similar symptoms from malaria, dysentery, and all other. So that index of suspicion, we've been picking signals from here, and yesterday we heard from the DRC authorities where their ongoing investigation are almost right now being completed. What they told us yesterday was on April 20th, there was a death of a patient. Always there's a spillover, there's a first case being detected, and then there will be a super spreading event either in a funeral or in a healthcare facility. So from the initial report they told us yesterday was April 20th, what's so-called the index case. And then the body was transferred on April 22nd. Why I'm spending some time here is just to put this in context because big statement needs to be supported with data. So April 20th, there was a death. April 22nd, that body was transferred. And May 5th was a super spreading event where we detected a social media report of deaths in the communities. The provisional government with WHO sent an investigation team on May to 12th, where they collected sample, did the EP investigations. Sample was sent to in INRP, and out of those 13 samples, 8 was confirmed. So between April 20th and May 8th, you can, in a highly malaria endemic zone, if you don't have that high index suspicion, if you don't have the right facility to test, you can, even in high income countries, you will have that delay in the start of an outbreak. So when action was taken, provisional government and the national government, and the results were available in 16 hours, in DRC, we just need to salute and appreciate what was done in a hardly complex conflict settings.
Thank you very much. And Dr. Belizer?
Maybe I can add to this.
Dr. Tedros.
Yeah. So this is very important, maybe on what the Secretary said. It could be from lack of understanding of how IHR works, you know, and responsibilities of WHO and other entities. We don't replace the country's work. We only support them. So that's why there could be some lack of understanding. But then, of course, there is a delay in detection, and there are many factors here. Number one is security. I said it in my speech. Ituri province has been marred with conflict for some years, but the last few months was even very intense. There was very intense fighting. And the last couple of months, even more. In April, I think the highest number of civilians killed. And more than 100,000 people newly displaced, you know, hundreds of thousands displaced in Ituri and live in camps. And displacement means not only displacement of the population, but of course, including the health workers. And you know, health facilities cannot work optimally there is conflict. And when the health workers are also fleeing as part of course, the community which is displaced. So it affects the whole surveillance system. And not only that, it also affects access. So I think it's very important to understand in what situation is even the surveillance itself and all the things that the country does is done. The country has good capacity, by the way, they have good experience. This is the 17th, and there was recent outbreak that they arrested it, detected it early and arrested it quickly. But this is more complex. So that I think that's what we should understand, the secretary or others. And then the second issue is, especially with regard to rapid field test, there was a problem linked to the traditional test we use. As you know, the traditional test is optimized with Zaire. And the same sample was taken and tested, but since the test kit is optimized with Zaire, it could not be detected. And then, of course, once samples were transferred to Kinshasa, and they tried to see if there are other things. The samples were transferred to the National Institute of Biomedical Research, INRB. It takes time. Imagine from Ituri to Kinshasa, and then checking all that is again adds to the complexity. But as you know, Bundi Buji has been detected, if I'm not wrong, in 2007. So it's very rare. That adds to the complexity and lack of optimization in terms of test kit. And then the third issue is, I think Abdi raised it, non-specific early symptoms. For instance, if you take malaria and typhoid, the early symptoms are the same. And the region is very endemic to those diseases. So the health workers, the early signs, they will associate it with malaria or typhoid, and they can't diagnose based on the symptoms. They may start treating. That also takes time. So it's very complex, and it's very difficult to follow a simplistic approach and say blame this or that. It's very difficult. But as far as we know, the country has capacity. They're trying their best, and they will do their best. But it's very important to understand the complexity, and before we conclude, bring all the factors into some kind of understanding of the complexity. It's not that simple. But from our side, we don't replace countries. This is the country's responsibilities, each and every country, but we support them. Thank you so much.
Thank you, Dr. Tedros. I understand that Professor Bloomberg would like to add.
I think the DG has spoken about Bundabujo and the diagnostic challenges. So thank you very much.
Thank you. And I'm just looking if anyone else would like to say something. If not, let's go to journalists online, and we will start with Jennifer Rigby from Reuters. Jennifer?
Hello, yes, thank you for taking the question and for laying out the challenges in detection. I appreciate that. But I just wanted to check again if there's any guidance on whether any of the funding cuts from wealthy donor countries to DRC or to WHO have contributed at all to the delay in detection or the availability of tests for this rare strain, or are hampering the response now. Thanks.
I think it's a brief answer again, the way I answered earlier. We don't need to jump into conclusions before we understand the whole complexity. So it would be very difficult to associate it with funding alone. So I would be happy to look at this properly and understand what were the pitfalls, and of course learn from this and improve for the future. Thank you.
Thank you, Dr. Tedros. Let's take 2 more questions from online, and then we will go back to the room. We have Janice Q from Bloomberg. Janice?
Hi, can you hear me?
No, we can't hear you very well.
Sorry, I'm trying to adjust my microphone. Is that better?
Yeah, it is better.
Great, thank you very much. I was trying to find out Merck's Ebola shots. I know that this is specifically used for the Zaire strain, but will it be given to health workers protectively? And the new promising vaccine candidate that was mentioned earlier by Professor Bloomberg, is that also produced by Merck?
Janice, I think you got cut. Sorry for that. Maybe Dr. Morty can answer the first question that we were able to hear.
Yes, so with respect to Merck's Ervebo, which is the licensed Ebola Zaire virus vaccine, that is a vaccine for Ebola Zaire disease. It is not a vaccine for Bundibugyo. There is, as part of the R&D blueprint determination, we have our usual processes which have been activated and are underway. So we have a vaccines R&D technical advisory group. We have a therapeutics R&D technical advisory group. So these review any potential for research evaluation in outbreak context. Those determinations are underway. And sorry, I'm not sure about the other vaccine. I didn't actually hear any other vaccine that was being talked about, but happy to take more questions.
Thank you very much. Well, Janice, as we didn't hear the second question, you can send us email, as everyone knows. It's media@who.int. Let's take one more question from line, and if we can have Kai Kupferschmidt from Science, who is with us. Kai?
Yes, hey Tarek, thank you so much. Just a really short, easy thing probably, but in terms of getting confirmed case numbers, are you planning to have sit reps up or anything like that? It's been difficult to get a good understanding of how the confirmed cases are kind of accruing and where to check.
Thanks. So yeah, we are supporting, and when I say we, it's our colleagues in the field working very closely with national authorities to get this the picture a bit clearer, as you mentioned. And our first priority is obviously to help the DRC and the Institut National de Recherche Biomédicale to scale up their diagnostic capacities in the field so that it helps improving the management of suspected cases, identifying who is a confirmed case, who is not, and refers them to adequate treatment. So this is all working in process, and we hope to streamline information in support of our colleagues in DRC to get you a clearer picture, but also for everyone to understand the chain of transmission and being able to stop them, to stop this outbreak. Thank you.
Marie-Rosaline?
Okay. Thank you so much. Just to build on what my colleague Anaïs already said, effectively, we are working side by side with the government of DRC, but first we're also working to have the trust of the community. One thing we shouldn't forget in that outbreak is that this community are already being affected by a species of another Ebola. So now this community take that they are protected from Ebola. And there's a new species from which they are not protected. It's very important that the trust and the community should be there. So the team is already in the field in Bunia, in Butembo, in Katwa, in Goma. In Goma, we have a team that has never left Goma, doing all the insecurity that has been there. So we are in the field, we are doing the job together with the Minister of Health and supporting of that community. For treatment center, we already identified together with the minister where we can place and do the treatment center. And you know, in WHO, what we really recommend to country is to have the response closer to the community in order to avoid resistance at the community level. So the treatment center are being places in where the outbreak is ongoing. So far, we have more than 13 health zones that has been affected in 2 provinces. So the outbreak is really spreading. It is a serious outbreak, but it is not this is something that we can control together. So other things that we are really doing is working together in joint coordination with Africa CDC in order to put all the resources together and to avoid duplication in the field. Thank you.
Thank you very much, Dr. Belizaire. Well, we have time for a couple of more questions, and let's see here back in the room, Stefan. And if we can really have one question per journalist, so we take a few more before we close.
Thank you very much, Stéphane Bissat from Le Temps newspaper. I have a question for Professor Bloomberg. You talked about your conversation yesterday within the emergency committee. Could you specify again the recommendations that the committee has made yesterday? Thank you.
Yes, thank you very much for the question. So our task was to decide whether this event constitutes a public health emergency of international concern. You heard from the DG that he had already declared this before the meeting. So we confirmed that we agreed with his decision and that this should continue. It satisfies all the criteria. We heard from the countries and about their actions and heard about many of the challenges. And our role is to provide additional or supported temporary recommendations to member states. That's around many of the things we've already discussed today, the need for R&D, the need to scale up surveillance, quarantine, and identification of contacts, safe burials. I think it's the usual outbreak response to Ebola, and we will be finalizing our recommendations to member states in the next day or so. But I think our prime aim was to support the decision and decide whether this is a public health emergency of international concern, and to consider where there's a pandemic emergency, but the former was agreed to. So I hope I've answered your question.
Thank you very much, Professor. Let's go to NPR. We have Jonathan Lambert online. Jonathan?
Hello, thanks for taking my question. It's about testing capacity. My understanding is that a shortage of lab test supplies and reagents was at least in part responsible for delays in confirming that this was Ebola. Can someone speak to the supply chain of testing and reagents and kind of where funding for this, as well as funding for the transport of samples, comes from and what might have caused the shortage?
Thank you, Jonathan. Anaïs?
Yes, thank you. I will try to be as little technical as I can. As you understand, the virus circulating is part of a genus of called ortho-Ebola-virus. It's a different species that the one that is called Ebola virus. I know it is not very easy to understand, and we apologize for that. We have taxonomists helping us on that. So there are a number of tests that can detect Ebola virus, all right? And there are also tests that can detect all the different ortho-Ebola viruses. But this is different type of test, requiring different type of capacities and platform for testing. In DRC, the reference national laboratory that is based in Kinshasa is equipped with the capacity to test for all filoviruses, so all ortho-Ebola viruses and all ortho-Marburg viruses. In the field, they've scaled up capacity in the past because of the previous outbreak, to the support to the people who recovered from the disease, the ability to detect Ebola virus on a platform that can only detect that virus. Now, we are working with INRB and other colleagues to look at different platforms, and there is a promising one, the one that is being used, and we are working very closely with INRB so that we can get good validation data that would be able to be close to patients, PCR testing, able to detect Bundibugyo as well. So we are using, sorry, they are using two different types of platform to ensure that detection is timely enough. At the same time, they are scaling up, and I think Marie-Roseline, you will want to complement that along with a decentralized approach, bringing care to patients and to communities, it goes with the lab as well. It is critical that we reduce the delay. In terms of supplies, the conventional PCR I mentioned that is able to detect for all filoviruses. There is no supply of that. The manufacturer has been producing and orders are ingoing. Similarly to the other kit I mentioned. So for the time being, it's not a supply issue. We need to ensure that the right platform with the right data, obviously, arrives at the right place. And this is the work that is being done as we speak. Over.
Dr. Ghebreyesus, would you like to add something, or Dr. Belizer?
Okay. Thank you so much. In addition to what Anaïsa said, I want to ask another layer of complexity, which is the logistic and to transport these material from Kinshasa to Bunia. So for so many hours or day, we are waiting for flight to go, and the flight has been canceled day by day. Even today, our colleague of Africa CDC should have lead to Goma, and the flight has been canceled. I'm leaving today in order to join the team in the field tomorrow so we can go there together. So it is to say that this outbreak is happening in a very complex situation. Not only we have the insecurity, the trust with the community, we have also the logistic that is very important because we don't have other mean that to reach a Bunia that we live by airlift. So it's really important also that we share those kind of complexity. So regarding the supply, I think Gigi mentioned that funding has been released as quick as 24 hours after the outbreak has been declared. So we also receive £1 million from FCDO, which we really say thank you because FCDO has been a partner who support a lot our work in the region. We also receive a fund from DG HERA. We also will be released $2 million from our regional emergency public fund that will be released to support. So the funding is coming, but now also when you have the supply, we need the logistic to be able in order to reach the field, which is very important. Thank you.
Thank you, Dr. Ghebreyesus.
Yeah, thanks for that. Just to connect some of the dots in many of the questions, whether it's around the laboratory itself, the supply chain, the request for CITREPs, they all lead to our absolute priority now is to identify all the existing chains of transmission. So this principle of identifying the chains of transmission is the same principle with every Ebola outbreak. And it's very important to get that right. And that's really where everyone is focused on at the moment, because that will then enable us to really define the scale of the outbreak and be able to provide, Kai, I think, ask for regular CITREPs, provide all of us the information we need both to manage the situation itself, which is then the priority, and then to scale the response in support of the excellent capacity that exists already in the DRC. We've been working with the Institut National Santé Publique, their new national public health agency, for a few years now, not only during outbreaks, but also in peacetime to scale their capacity, to grow their capacity, collaborating with them. INRB is a well-known, world-renowned science establishment already with a lot of capacity. My colleagues have referred to the challenges in logistics in the country, the humanitarian situation, the challenges with conflict. But between all of that, this is what we need to do. Now, the final point on this, on identifying chains of transmission, is the biggest lesson we've learned through all our Ebola responses is that we can't do this without prioritizing the community. So if we think that we are going to jump in there and solve all the problems, which is the instinct of many people working in this field, then we will not have learned the lessons of history. So the lessons are that irrespective of the pressure right now to go in, to do, to jump, that we have to work with the national institutions, the communities, the people. It is only through them and the confidence that we can build in them that we will be able to identify these cases, isolate them, identify the contact, isolate the cases, treat them, identify the cases, treat them, identify the contacts, isolate them. This is not possible without the community. So yes, there's a lot of pressure for us to answer all the questions right now, but I also solicit a bit of patience as we figure out what is going on, what we need to do, and deliver an appropriate response for this to support the people and the government of the DRC. Back to you, Tariq.
Thank you very much, Dr. Ghebreyesus. We are really approaching 12 o'clock, time we would have to stop. Let's take like the last two very short questions from Jamie and from Laurent. So Jamie first, then Laurent, and very short and one question.
Thank you very much. Dr. Ghebreyesus, you mentioned a question that I wanted to ask, but I just wanted to go back. So Madame Legon, you said that earlier that you're thinking that this has started probably a couple of months ago. And I note that the number of suspected cases is continuing to grow. I think it was 500 yesterday. Today it's 600, you mentioned. So based on those dynamics, what is your projection about how long this outbreak could last and how many people could be affected? Basically, to give us an early idea of what you just mentioned, Dr. Ghebreyesus, about defining the scale of this outbreak. What are your early projections about that? And I just wanted to ask another quick one, which sort of alludes to what you said. Infodemic and cultural disbelief came up from the WR yesterday. What do you do? We have a team on the ground around Bunia right now. What is being done locally to try to help address that infodemic, which is a term that Director General has used very often in the past, of course?
Thank you for putting me in the spot. I'm not a modeler, so I will not be able to answer your question precisely. We know there are teams ongoing. There has been a couple of modeling studies that have been published. Again, currently our understanding is focusing on what we can do now, cutting the chain of transmission and helping communities. And I think I'll differ on what's being done to my colleagues. That being said, we will not wait for this virus. So we are already scaling up. And as things evolve in the field with the capacity to diagnose, with the capacity to isolate, with the capacity to care, we will get a better understanding of that. But right now, our priority is to focus on supporting affected communities with the full response capabilities as close as possible to them. And I'll defer to you, Marie-Roseline.
And Dr. Janabi as well. So Dr. Janabi, then Dr. Balizek.
Yeah, thank you. Maybe what I can top up regarding the trajectory, it is too early to provide any precise projection on duration or total numbers. However, experience tells us that trajectory will really depend heavily on how quickly we can scale up case detections, like my colleagues have said, isolation, community engagement, which Chikwe just mentioned, and infection prevention measures. So at this stage, I think that could be the best response.
Okay, thank you. So we receive some modeling studies because we are working with some partners. One of them is the Imperial College of London, who just released some modeling studies. So based on that study, their estimation, we are talking about modeling. So they estimate that we can have two scenarios. One of them is between 400 to 800 cases, that could be. And also one of them the worst scenario could be 1,000 cases. So they use the method of geographic spread. That is one of them. And the second method they use is the back calculation from death. So far, as a number of deaths, how many cases they can produce in the community. However, there, as my colleague said, they are estimation, and the reason why we are going on the field with my colleagues, epidemiologists, and also clinical care from HQ in order to have a preliminary assessment that can give us an idea on what are we really talking about, what is the extent, and what could be really the starting date of that outbreak, so that can give us an idea on how we set up this response. But we already agreed that the response, we will scale it up. We will not wait to scale. We will really starting a scale-up response, and after 3 2 months, if the situation is under control and there is a need to scale down, so we can scale down. So that means we are using the no regret policy and no harm policy of the emergency response program in WHO to scale up that response as big as possible. Yeah, thank you.
Thank you. And then let's have a last question. Laurent, please.
Yeah, thank you, Laurent Siro, Swiss News Agency. DG, you mentioned the volatile security situation in the eastern part of the country. Do you call the M23 to reopen formally the Goma airport in order for supplies to get faster? And linked to that, do you plan the deployment of international rapid response team and the IHL, or on top of the WHO team that you have already on the ground? Thank you.
Thank you, Laurent. I'm just looking who would like to... Dr. Tedros? Oh, Abdi, whoever.
I can start.
All right, Dr. Ghebreyesus.
Yeah, I'll take the second part of the question first on the deployment. We already have, firstly, we have a big WHO team already in the affected areas, like my Roslyn said, in almost all of them. They've been there. It's the reason, together working with the national authorities, that we understand there's an outbreak at the moment. And we've been scaling that up, supporting the national authorities too, to deploy their colleagues from Kinshasa to Bunia. In addition, we have a joint cross-WHO team already on the way from both the regional office and HQ, depending on skills that are needed and capacities needed, and we will scale that as required over the next few days continuously. Now, the principle of how we respond to outbreaks has changed significantly over the years. So we will work with the local communities, identify where they have gaps before we fly down any troops to go and save them. The whole principle of how we work has evolved a lot. We respect the capacity that they have built. We identify any gaps, we discuss that with them before we start thinking about who is to go. So that's exactly what has started happening from the very first day, and how we are responding to the needs on the ground. I'll let the DG respond to the opportunities to maybe discuss the airport and general access to the Eastern DRC.
Yeah. As you know, the epicenter is Ituri, and of course, that's where the center is now. And colleagues have already traveled to Ituri, so there is no access issue. Based on how the disease spreads, if there is any access problem, then we will address it. But now we're focused in Ituri, since that's the epicenter. Bunia Airport, yeah.
Just to add on the point about the international surge, I just want to recognize all the health clusters and the mission hospitals who have been providing cares. Yaoundé Medical Hospital, where we had our American doctors providing, was attacked in 2002, destroyed. This team were there, came back, stayed there. the history of Ebola has always been defined by mission hospitals because the love and the compassion they have. From 1976, it was Yambuku, and now the mission hospital there. Just I want to recognize that the healthcare depends a lot of health clusters that have been providing health service before Ebola, and they will continue to stay and recognize all the faith-based who've been working in remote, difficult areas, providing care and health services to neglected and marginalized population.
And Dr. Belizer, you would like to add final word?
Just a last word to say that our team has never left Goma. We always have a team in Goma, and we always continue to provide our support to the population. And this is what we will continue doing, this outbreak in Goma. So we never left Goma doing all the insecurity happening. So we will continue staying to provide the security to the community we serve. Thank you.
Thank you, Dr. Belizer, and thanks to all our speakers. This will bring our press conference to an end. We apologize to journalists who had their hands up online, also some journalists here who may have had more questions, but don't hesitate to contact us on media@who.int if we can assist you in any possible way. We will be sending the audio and video file of this briefing shortly to our media list. I give the floor to Dr. Tedros for his closing remarks.
Thank you to all members of the press, especially Akanu, for joining us today, and see you next time. Thank you.